TopMedTalk.
Nick Majerison here. This piece was recorded at last year's 21st Current Controversies in Anaesthesia and Perioperative Medicine and SIAA Autumn Congress at the Dingle Skellig Hotel in Ireland. Have a listen.
I'm delighted to welcome Desiree Chappell, who has come to us from Kentucky. Desiree is a nurse anaesthetist in the Norton Audubon healthcare system, and there is team leader for enhanced recovery after surgery. She is also an elected national representative in the enhanced recovery setting and a contributor at high level to the USA branch of evidence-based perioperative medicine. Desiree is going to speak with us today and educate us with a contribution from Professor Mythen about enhanced recovery after surgery, which has implications for all of us who look after patients. Thank you.
Thank you to the Dingle crew, Monty, Mike, Kay, and Jan for the invitation and bringing me into the Dingle family, the meeting, the setting, everything about it. And I also want to just acknowledge that this has been an extremely tough year for the Dingle family because of the loss of Siobhan. And I know some of you guys are just here today or have been popping in and out, and I think you guys have done a wonderful job honoring her and her memory this year. And for Kay, who is, I think she's probably still out manning the desk, everyone give her like a huge hug and a thank you for taking over and keeping Dingle and this meeting part of our lives. So I just want to say that. Katie, thank you for the introduction. It's changed a little bit. I was full-time practicing CRNA in Louisville, Kentucky until last year when I decided to take the jump off a cliff, really, some people would say, into the world of podcasting and trying to spread the word about perioperative medicine and enhanced recovery specifically through new forms of communication. And so Monty had the foresight, I guess, to bring me into the TopMedTalk family, which we've kind of talked a little bit about, and we'll talk about it in just a moment. But I decided that through my experience with enhanced recovery, I'm full disclosure on the board of the American Society for Enhanced Recovery, also EBPOM USA. It was through all that I decided we needed to start sharing this information in different ways. For our session right now, I'm going to do my session as a podcast, a live podcast, what Monty and I would normally do, and have a discussion about it. We've seen lots of slides. I have some slides, and everyone's done a great presentation, but we're just going to mix it up a little bit for you today. So I'm going to invite our Editor-in-Chief of TopMedTalk, Professor Monty Mythen, up to the stage. So the topic we wanted to talk about was enhanced recovery updates. We've heard a ton about it. The free papers that we heard this morning talked about it throughout the entire meeting. Monty, thank you so much for joining me. I know it's the last minute to bring you up here, but I'm wanting to change it up a little bit. So one question I wanted to ask you or talk to you about before we get started is, what are you thinking about the Dingle meeting so far?
No, I think it's been wonderful. It's been challenging because of the reasons that you stated, but the fact that the local community here and everyone who comes along has been so supportive, I think it's been wonderful. And I don't think you can knock the quality of the content here. So it's world class, so let's keep it going.
Yeah. So TopMedTalk.
We should explain a little bit more about that, why don't I? So we commonly do this now around the world with different people. We do basically what looks like chat shows or interviews to draw more information out of people. And we record lectures off the stage and about 700 podcasts. Yeah. So we send one out every day. We do. And if we put into our, does it cost anything?
No, it's completely free to everyone.
So completely free. So if you put TopMedTalk, TopMedTalk.com, you'll get into our website, and in there it encourages you to subscribe. Why, if there's no money involved, why subscribe?
Well, if you subscribe, you'll get podcasts delivered to you every day, and you're part of the TopMedTalk family.
And if you download the app is very user-friendly, and it has a great search engine in it. So this morning, when we're doing a little bit of prep, because this looks spontaneous, but we do prep a little bit. If you put enhanced recovery in, you get over 100 independent podcasts about enhanced recovery, including one of your favourite interviews with...
Henrik Collette. And actually, Angela Bader, some of the greats, you.
So who was your favourite podcast of all time?
It's probably Henrik.
Henrik Collette.
Yeah, Henrik Collette.
So we do have in there, for example, we've got Bill Clinton.
We do.
Talking about hand washing. didn't actually interview him, but we're in the room and we were allowed to
we recorded him.
We were allowed to record it with permission. We were in a relatively small group and patient safety, and he spoke passionately about the fact that his mother's an anaesthetist,
nurse anaesthetist.
And how important hand washing is. I didn't see any evidence of it, but
no.
So we should probably get onto our subject.
We should, yes. So, and it may feel like a shameless plug, but honestly, it's a huge wealth of information. So, all right, enhanced recovery, Monty. We talked about this study earlier in the year, the POWER study, and one of the things that I think is great is it shows that enhanced recovery is it's working.
Yeah, I mean, I think that there seems to be global agreement now that enhanced recovery is the modern way of caring after patients perioperatively. Now, for some people, it's been that way forever. So immediate post-operative mobilisation and immediate post-operative feeding has been in certain parts of the world for centuries. It appears to be that the Brits and the Americans got together and suppressed that idea coming out of Central Europe and the Far East ages ago to create this modern-ish paradigm of leaving people in bed and then somehow being starved and immobilised, enabled recovery. That was all made up by us, if you see what I mean. Shame on us, and we're now unpicking all of that. I think the only pushback from people is some people say we don't do enhanced recovery, we just do something that looks exactly like enhanced recovery, but we like to call it Kentucky Fast Track or something different because we're not doing enhanced recovery.
Yeah.
But the principles, the immediate post-operative drinking, eating, mobilising, seem to run through all of those systems and seem to produce enormous benefit. Yeah. So just getting people to live the dream, drink, eat, mobilise, seems to be the secret.
And it's shown it works, but the compliance is the big thing.
And that's what this paper here, this is number one of a whole series of papers. This is a longitudinal cohort study, as I remember. And it once again points out that if you don't have an enhanced recovery program, you're typically doing about a 60% of the enhanced recovery elements. If you do have an enhanced recovery program, you need to do about 80% compliance levels to get the return on the investment. So if you print the protocols and you print the T-shirts, but you don't walk the walk, you just wasted money. Right. If you get the compliance levels, you get the return on investment. Now, the big known unknown there, sorry to bring that one up again, is whether it's the compliance with the elements that makes the difference or whether it is that effective teams comply. So whether it's just a surrogate measure for being good.
I really feel like it is starting to spread, and we get a lot of feedback actually from people all over the world talking to us about what their experiences have been in countries that I never would have thought about. And this particular one was from a woman from Saudi Arabia, Fatima, was telling us that she was over in the UK and US to do a fellowship in learning more about enhanced recovery. So I think the global spread, it's starting to make it out.
I mean, as I said earlier, I think that every healthcare system in the world now, either by calling it enhanced recovery or fast track, or just emphasising multimodal analgesia and, more careful management and pursuing drink, eat, mobilise, I think everyone's in now. If you're not going to do it, I think you're running out of places to hide, basically. Yeah. And I think the insurers in the US are now starting to say, we only want to buy enhanced recovery programs. We're not going to buy that other stuff. Yeah. Because as one of your surgical colleagues in the US said recently, why would you pay for unenhanced recovery? Right. Why would you pay for a slower recovery and greater misery and complications?
Yeah, and I think patients are starting to pick up on it too and calling.
Yeah, you have adverts in, I think actually outside Vicky's town, I drove past an advert bragging about enhanced recovery. So it's going to be in a magazine in the back of an airplane seat soon.
We can only hope. Well, one of the things I think is interesting when we talk about the spread of information, and people laugh because I put social media on there, but and I think that is Snapchat in the middle. I'm not really sure what that is. Anyway, I think the sharing of information is really interesting.
That's a good pub quiz question for the over 50s.
It is. Yeah. The little yellow thing in the middle, what is it? You youngsters in the back will know that.
Ghostbusters? I don't know. I recognised 5, I think.
Yeah. Well, yeah, we're on all those actually. But one of the things, and we talk about this because you said if there's a new paper coming out and it's great, it's big, like it's going to be within days or a month.
Yes,
spread, right?
I think our trainees know about the latest news within seconds now.
Right, but I think they're actually getting that on social media, Monty.
Yeah, absolutely. But I mean, also from the point of view as it's spoken on the stage.
The
youngsters are sharing it straight away. They're skipping the sort of publication stage.
But I think it's great, though, especially in this global situation that we're in, that we're trying to communicate across the world. And in my personal facility, I work in a smaller community facility, and word doesn't spread that fast, and now we have social media to do that. And I think there are groups all over the world that are posting really important information, important papers, what they're doing to spread the word about, in perioperative medicine and enhanced recovery, that it's not just sharing of information, it's actually having conversations and connections and contacts across the world, that you can have all of this in, completely different places and talk about the things that are important to them.
I think people are sharing best practice. They're sharing their results.
Yeah.
They're less obsessed with the idea of the evidence base being entirely dependent on the large prospective randomized controlled trial. This was referred to yesterday, I think, in the keynote lecture. Yeah. The little bit of work I've done at government level in the UK, they have a 5-point evidence construct. And number 5 is the things that we obsess about, is the prospective randomized controlled trial published in JAMA NEJM. Yeah. From their perspective as a government payer, they say, Go tell me who's got the best results. Yeah. Find out what they're doing. Ask people to copy that, and if they copy it, do they get the same results? Ask the clever people if they think the biology makes sense, get some sort of triangulation. Ask the big societies and the collective groups if they think it's a good idea. And if you can knock out a trial eventually, that would be great. But we can't wait 15 years to get on with it. Yeah. And that's that kind of, and we got it in Chris Snowden's getting it right first time yesterday as well. Look around and see who's got the best results and just ask them what they're doing.
Yeah.
But beware of unintended consequences. Yeah. Which is referred to in the end.
Yeah, it was, yeah. So when I say enhanced recovery is really spreading to other organizations, professional organizations, I think, are the biggest thing. Both of us have been speaking at nursing, at least in the U.S., nursing organizations which just 2 or 3 years ago had never even had anything about enhanced recovery in their professional meeting, their organizational meetings.
Well, whether you call it enhanced recovery or not, that some people do have antibodies to the title. Let's pay meticulous attention to everything with regards to preparation, delivery of care, and in particular, getting people going as quickly as possible afterwards in their best interest. That has spread to everyone. It's revitalised a lot of people because it's changed the role of the OT, the PT, the physiotherapist. It's re-engaged the dietitians. Yeah. We've sort of dragged out the fact that our perioperative nutrition is pretty poor, and the return on that investment is great. The prehabilitation idea is growing very rapidly. There's what was the prediction that it's going to be the word of the year next year?
Yeah. When prehabilitation doesn't autocorrect.
That's supposed to be the acid test is when you put prehabilitation in. If it doesn't autocorrect on the auto spell, then it's arrived. and it's just starting to not autocorrect the whole time. So.
Yeah. We must be geeks, though, for texting that to one. It's cool. We're the cool people.
There's a World Prehabilitation Organisation now. So that was the meeting we had in London, which was the 3rd gathering. Yeah. The first one was a small room of people. The 3rd one was sold out at 700 people. Yeah. And next year it's going to be bigger and bigger.
Yeah. Super cool. One thing I think I put pharmacy on there, and I know whoever started an enhanced recovery program or anything like it, or just trying to get a new drug on formulary, pharmacy is dragging their feet all the time. And so I think just recently, within the last couple of years, again in the U.S., that they're starting to talk about at their meetings, and that's really how we're going to get spread and adoption within them.
And I think George was just referring to this, the unintended consequence of the so-called opioid crisis in the pharmacy around enhanced recovery, because prescribing things is relatively easy. Yeah. For some people's enhanced recovery is everyone's going to get gabapentin and everyone's going to get non-steroidals, not adjusted for age or creatinine. It's, there are unintended consequences of believing that there's a single recipe that equates to a drug pattern profile. And I think we've seen quite a lot of the unintended harm from, everyone's got to get a non-steroidal, but they're old, they're frail, their creatinine's elevated, steady on now.
Yeah, well, that's a more cause to really bring them into the conversation because even though we know those things, I think that having that conversation about it's going to only improve that.
We touch on, because government's interesting. Yeah. So, the United Kingdom made a conscious effort when it was really on its knees financially to go for the national spread and adoption of enhanced recovery. which seemed to go extremely well with a high return on investment. But it's interesting, if you saw Chris Snowden's presentation, how much that slipped back since 2010 or so, because we've had extreme austerity measures, which has included, let's save as much money as possible, which has included not collecting and sharing the data, which has allowed people to revert to the norm, which is, all that enhanced recovery nonsense doesn't work. I'm going to go back to doing what I used to do, because now I can say I'm right, because I don't know what happens to my patients and no one's sharing the data, so I can go home feeling good about myself.
Yeah, no, totally. And I mean, in the US, I mean, Vicki talked about it yesterday, it's plus or minus. I think we're starting to have conversations, but we're getting there. But I think, it's something we need to definitely work on. So I don't know, you hear still a lot about enhanced for colorectal, but I feel like, especially in the US, we're really starting to expand rapidly into different service lines. And I mean, we've heard about obstetrics. We're probably going to hear about a little bit about it more today. Spine, all the different ones. And cardiac is kind of a big one coming through the US right now.
So Kaiser Permanente, for example, I don't know if everyone's familiar with it, which is a sort of dominant insuring healthcare providing group, mainly out of California. Their headquarters, they published a couple of articles where they did a colorectal pilot, a fractured neck, a femur pilot, and they not only reduced length of stay and major complications, they decreased mortality. So when I went to visit their headquarters at their invitation, they told me their mission is to go total ERAS. They don't call it ERAS, they call it something else, because you've got to make up your own name. But Kaiser Permanente Fast Track Special, they're going to have that philosophy, they say, through all of their institutions, but not just for elective surgery, for emergency surgery and for common medical conditions. So I'm going to say, if you come in with a pneumonia, for example, why should you not have the same principles? In other words, why wouldn't you want to get drinking, eating, mobilising and home as quickly as possible, rather than put in bed and shackled to it? So we'll see how that goes.
Enhanced recovery after cesarean.
Yeah, so we, in the UK, when we got to the end of our National Enhanced Recovery Programme, someone said, well, what about the C-sections? And we said, well, don't they all go home as quickly as possible?
Yeah.
They said, no, they're the biggest bed user in the UK.
US as well.
And it's not, you know what I mean by the biggest bed user. Of an elective surgical procedure, caesarean section patients occupy the greatest number of bed days.
Yes.
And the length of stay is 1 day in very many places, but it's 2 in a lot of places, and it's 3 in some places.
Yeah.
Now, as I understand in the USA, which I found to be shocking, is by law, you're allowed to stay in 4 days. Mm-hmm. That's not unusual, isn't it?
It's not.
There's a massive bed occupier, but also, did you want to be in hospital for... Well,
there might be a chance that I could have wanted to stay an extra 1 or 2 days if somebody else is watching my kid, but I mean, no.
I've given away... Well, you've talked about it on podcasts.
I have talked about it on podcasts a lot.
Let's ignore whether people want to go home quickly.
Yeah.
All mums would appear to want to be up and about and able to look after their baby as quickly as possible.
Absolutely.
So that's and that's happening very rapidly in the US now, isn't it?
Pain control is the big thing on that one, and if you can get pain under control, that's good. So there are new guidelines that are coming out. This is one we've talked about quite a bit this year on TopMedTalk. We've seen a lot with the cardiac guidelines from the ERAS cardiac group, and we actually did an event with them earlier in the year talking about what the recommendations are. So when we looked through this, Monty, we were kind of counting all the enhanced recovery principles and things that were unique to cardiac and versus what were...
I mean, as you might expect, one is to back up a little bit. The reason we didn't do cardiac when we did the UK programme, and I guess it's very similar in Ireland, is we have relatively few cardiac centres. So when we look at, and they almost all trained each other. So when we looked at our cardiac results in the UK, our length of stay was plus or minus a day for the major procedures. When we looked at colorectal, it was a threefold different. It was 6 days to more than 18 days. So we had this sort of huge scattergram. With cardiac, it looked like someone had dipped their thumb in some ink and ran it down the sort of day 6. And it was a really tight cluster because there aren't many centres, and you go into any of them and care looks pretty much the same. Now, I can see the motivation in the US because you do a lot of cardiac surgery, and your outcomes are all over the shop.
Yeah.
I mean, you're in the colorectal space from that.
It's exactly. Yeah.
So I can understand why they had the drive for it. Now, if you look at the guidelines, there's about 3 things that are cardiac-ish.
Yeah.
A bit of coagulation stuff and a bit of how to look after the wound stuff. But almost all the rest of it could have been colorectal or orthopedic. Yeah. It says multimodal analgesia, get them prepared properly, get them drinking, eating, mobilising. And also, they've sort of pushed out into the perioperative medicine space. They're saying, fix the anemia, and they've got the P word in there, prehabilitation. So it's apparently making rapid changes in centres. Also, interestingly, that they focus quite a lot on the intraoperative care package because something's gone awry in cardiac surgery in the last decade or so. There's been this obsession in some places with high-volume ultrafiltration to make the blood look thicker at the end of bypass. It's completely out of control, and some centres have an AKI rate of 40%, whereas others say they've eliminated post-cardiac AKI. So that's a very, very hot area at the moment, is to say, get a grip back on that craziness that's happening.
Yeah, it is.
During the case, just to make the blood look thick for a few hours.
It's ridiculous. I mean, I've lived that myself right now, and trying to change the dogma has been very difficult. I will say, though, for enhanced recovery program adoption in the U.S., they're kicking it. Like, they are killing it because it's this huge marketing campaign. You see them all over social media. You see them in every organization. Doctors, nurses, whatever. And they're doing a huge marketing campaign, and that's part of it. One of the guys in the free papers was talking about that earlier.
The training courses that I've been to one of them. We went to one in Wake Forest. They brought together teams where the surgeon has brought with them the key players in the team, and they've got together 10, 15 teams in a room this size, and in a day they've shared best practice. And then they've agreed to go away and do something about it. And that means that they're spreading it virally with a high level of, let's not reinvent the wheel every time we share the love. Let's do it truly viral. Let's get this virus to be a pandemic. Let's see.
Where's Dan Martin? So the perioperative quality initiative, Monty, I always talk, anytime we talk about enhanced recovery, I always bring up this group. And of course, you are part of that, and Mike and the team here. But I really think that they have some great recommendations. And I don't know if everybody understands what POQI is.
Well, POQI, Perioperative Quality Initiative, was set up by 5 founding directors. It's modelled on ADQI, which was the acute dialysis quality initiative. It is now the acute disease quality initiative, and that's been running for about 20 years now, and it produced guidelines and criteria like the RIFLE criteria. So the methodology that's used is slightly unusual. It's a modified Delphic process where you pick off some subject areas, and the most recent one we've done, which won't be published yet, is about post-operative acute kidney injury. People from around the globe with different interests and expertise have a run-in period of a few months where they identify what they believe is the most pertinent literature. And then picking off about 3 subject areas, they get together in a single plenary session of about 20 to 30 people. They present their initial findings. That gets challenged by the group. Then they break out over 2 days, multiple times, until they reach consensus. And then they produce these guidelines that are quite often eminence-based, but they also have grade in it and level, proper grade process, distillation of the literature. But they get off the fence with regards to making consensus recommendations, even when you can't necessarily find a lot of evidence to support it. You say, collectively, this is, we think, what people think is the best thing happening in this space at the moment. It's all free, it's all open source. I think we're up to the 7th or the 8th, so we're up to 15 or so publications now.
Yeah.
POQI.HQ, I think it is. .org will get you there as well.
Yeah, it really is a great resource. And the thing that I love that you guys have been doing is doing joint consensus statements. So there is with the American Society for Enhanced Recovery. So it is a great opportunity.
The one we just did is ADQI with POQI because it is a post-operative acute kidney injury, transitioning into chronic kidney injury. No revelations in it at all, but that's reassuring.
That's what I was going to say. What came out of that?
It says don't poison patients and avoid hypoxia and hypotension, but when you're avoiding hypotension, don't just squeeze, do it. Be smart.
The catch to enhanced recovery is not that the data is not there to support it, because I think it is, but it's the change management piece.
Absolutely. As I said, harping on about my UK national experience, they gave us relatively little money to run the program, but they did give us the data, they gave us analysts, they gave us implementation scientists, and they gave us change management experts. And if you want to, I would invest in change management experts, even if it's just for a few weeks.
Yep.
People who can kick butt properly.
Yeah.
So they don't care who you are or how allegedly important you are. If you've come here for a team game, one is turn up. If you don't turn up, your team has to go away. And two is listen, concentrate, go away, do something and come back. Fantastic.
That's good. So the last thing I said, so that's what we were talking about earlier, is like the implementation science, all these things, but the human factors, and this kind of ties it all in, because I found this on Twitter from the periop group at Monash in Australia. They're doing like a human factors course, and this is it. This is how you get change.
That's the recurring theme. I think we had some presentations earlier in the week about enhanced recovery. Downloading a recipe is not difficult. Printing out the algorithms isn't difficult. Describing what you're going to do. We're just really awkward people.
Yeah.
The ethnography that's been written up about some of the large quality improvement initiatives, we're just awkward cusses, largely speaking.
Yeah, that's exactly what it is.
We get into our room, we know better, we're going to do our thing. Don't tell me about my outcomes, I don't believe you.
Yeah.
Because they look great when I left.
Yeah.
So that's the secret.
Yeah.
The human
secret sauce. All right, thank you guys so much for listening.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.